For our expert, we have Dr. Sabnis sir.
You can add.
Can we ask Makarand Kochikar and utilize his presence as mentor, both of them?
No, I think both of them can sit there only.
No, let them sit here. They can function well.
Okay, one more.
Yeah.
One more. But I think it doesn't matter. Let the panel be there. One more chair is there. I think give a mic. You sit there. You two people sit there. They'll get nervous, man. Come on. Don't make them nervous. Come on. Okay, give a mic there. Am I right? Okay, I'm audible. Well, I don't think there are some complications.
We can make you nervous also.
Acha, you. Oh, sorry. Well, I don't think there are any complications. Some lessons learned out of our experience. I think I'm just sharing those lessons and how we read those lessons in our own way. I asked Tarun also to join there so that he can actively participate into it. The first case, hypertrophic cardiomyopathy, CAD, incidentally detected left upper polar mass lesion in December 2020. I think the picture is quite clear. The left-sided upper posterior part of the hilum, and that is another picture, and I'll play the video. And we did, as usual, we thought of doing a robotic partial nephrectomy, and we see this. I think everybody is seeing that video. At one point of time, we see that, again. During partial nephrectomy, there's a thrombus into the vein. Can I ask, I'll just stop it here. That's a picture. Gautam, what are you going to do with this?
We'll go ahead with partial only because tumor seems to be,
I think I should be getting it away, I think possibly without any problem, am I right? I think that should be possible to take it away.
Yes, sir.
Right? That's so I mobilized it a little more, trying to understand is the open vein there. I open that vein and I see that the vein is completely vacant, and then that's a sinus fat and the thing. All the panelists are agreeing upon it? Anybody differs?
All agree.
So all agree on this?
Yes.
Right?
Yeah.
Tarun, you also, I think? Fine. So all agree, okay. Fine, that's wonderfully done. Over. Okay. So we finished it, and that's a tumor thrombus, and that is sinus fat. The partial nephrectomy has been done. Okay. The post-op uneventful, patient went home, there was no problem at all. Okay. It came out as a clear cell carcinoma, grade 3, and segmental vein thrombosis, margins free. Okay, it has become T3A. How far, you all believe that T3A is a partial nephrectomy, right? You all believe that, that's what you believe now. Okay, that's fine. He came back in 2024 and he said he has hematuria with clots past few months. Ultrasound KB prostate shows mildly swollen left kidney with a dilated PCS, blood in the dilated system. Serum creatinine is 1.7 now. He has his CKD now. So we did an MRI, which with great difficulty we did. This is a picture. What will you infer now?
Different tumor or recurrence?
That is a picture of MR.
I will go for biopsy.
Well, this is the picture of MR. There is no tumor. Basically, it looks as if it is a segmental infarct of the upper pole of the kidney. And it was reported, in fact, as some sort of a focal segmental vein steno-occlusion they reported as, because it appears as if it is a segmental infarct in the kidney. What next?
Can you just go back for CT scan, sir?
No, that's all MR only.
Oh, MR only.
MR only. I can replay the same thing again if you want.
Yeah.
Okay, from here I think it's better. The other T2 images, yes.
Sir, is there any mention of a pseudoaneurysm kind of thing?
Nothing, it's 4 years later.
Okay, 4 years later.
This is 2020 and 2024.
And he had hematuria.
He had hematuria, past 3 months. 2 episodes of hematuria, first one treated as prostatic obstruction and later it was investigated. And they could not find the first time, they could not find anything. Even that irregularity in the kidney was not identified in the first episode.
Biopsy, because difficult to understand.
Where to do a biopsy?
No,
You're not
first-
having any identification there.
Yes,
It's
yes.
all upper pole is completely
Can
segmentally.
we go MR angio like to differentiate any AV malformation? Definitely where from it is bleeding, where is the communication, and if the doubt, then
No, I don't think. Do you think anatomically the way it looks like? Do you think that it's a AV malformation? Like thing I'll
I don't know. I'm not good in analyze.
No, I understand. The
MRI.
picture is seen at that point of time is similar to see this. Oh, sorry.
Yeah.
It looks like a definite lesion on this section at least.
Yeah, there is a lesion.
Yes, so
There is a lesion which is similar to a shape of the kidney, and it absolutely looks like an infarct of the kidney, right? If you see a CT scan or an MR on a segmental infarct, it looks like that. Focal pyelonephritis, it looks like that.
Sir, if it is presenting 4 years after the initial surgery, why would the kidney wait for so long to get infarcted?
That's I
there is,
understand.
and there is definitely something happening there which
Do you
gave
think
rise
that
to
it's a tumor
hematuria.
after 4 years?
It can be a second primary in that same kidney.
Do you think that shape, everything goes in favor of that?
But we have distorted the renal anatomy when we did a partial nephrectomy. And anyways, when we have a doubtful lesion where nothing works, we can do a biopsy.
Don't you do a PET scan? So non-contrast PET scan?
So the reason why
Okay, you have a PET scan, non-contrast PET scan. You don't need to justify not doing it, but you have got it done.
Yeah, so this is the reason why I would not go for a PET scan as a first choice,
Because
because
it is not
FDG
seen.
itself,
I understand.
for a local
Absolutely.
staging of the kidney is not.
Absolutely.
Biopsy.
Biopsy. From where? Any part of the kidney?
Yeah, ultrasound guided.
Upper polar?
Not from the representative area.
There is no representative. It's all upper pole. This whole thing is there.
Yeah, then we from.
If we look at the top left lesion, the appearance of the kidney is very similar to what an RCC would look like. So we can biopsy that. If we have a non-contrast CT, which we did as a part of the PET protocol, then we can definitely have a CT guided biopsy.
Wonderful. Right. We got an ultrasound guided biopsy for all as you expected. It turned out to be a clear cell morphology, probably malignant. This thing. So we went ahead and did a laparoscopic radical nephrectomy and see the way the tumor appearing is here on either side.
Recurrence. Local recurrence.
The present, when do you say that vein is with muscle? If you look at the present classification, if I remember this is the correct one at the recent most, if both the experts say yes, that's the last one. What do you say, Makran? That I don't think there is any modification after that?
No.
No, fine. So with that, it's mentioned here that there is a segmental vein, muscle containing vein. How do you differentiate it on the table? What do you mean? No, that's where the classification is now. That's exactly what I'm trying to say. Why I'm presenting this thing is, number one, there is an indication to do a partial nephrectomy with a T3A disease, which is an upstaging of some sort of a modification which has happened in the staging of the renal disease. And now you find, if you have a muscle, segmental vein invasion with a muscle containing, that means it is a T3A disease. That part is coming. We are talking about doing a partial nephrectomy in a T3A disease. Can we do it or not? So how do you identify whether it is a segmental vein or not segmental vein?
Malik, I think I'll make a point here.
Yeah, please go ahead.
Many times when we do these kind of procedures, with the larger tumors, I think I don't know whether the imaging was done prior to the surgery, because at tertiary center, you get the images done outside. And when we have aggressive tumors, we make sure they get one repeat color Doppler and ultrasound, just to make sure what we're dealing with. I don't think we would have done anything different than what we have done.
No. First thing, I don't think this sort of a small thrombus, which is around 3 or 4 millimeters, will be picked up on an imaging process.
It would be.
It may not be. That's what I'm saying.
The extent of thrombus, what you have in the segmental vein.
1 centimeter.
Yeah, but significant it was. But ultimately here what we are talking about the biology of the disease. You had a large tumor, you had a segmental thrombus. I don't think we would have achieved anything by doing a partial nephrectomy in these kind of patients. So forget about T3, forget about sort of muscle invasion into the vein itself.
My point is very clear. We are doing a partial nephrectomy, we will find this lesion. The tendency of the people is to do a partial and go ahead with a partial. How far we are correct in that? Anant, let Anant comment and then I'll come back to you. Go ahead.
So I don't think we're meant to find out on table. These classifications are
Or after that?
post.
Yes.
So if you think it's partialable, do a partial. And then when the report comes, we either do adjuvant or...
Shall we do, or we need to wait?
Usually it's wait, 99% wait and watch.
So we are getting into that tendency of doing a partial whenever it is possible, but be prepared that it can happen. Subnis.
Actually, the heroic partial nephrectomy, I know the thing is going back again. Large tumor, central tumor near the hilum, all these findings intraoperatively and still continuing to do partial nephrectomy. Eventually, the histology and other things going to be a problem.
Retrospectively, do you think that I did a correct thing doing a partial there?
No, at that time, everybody will do the same thing. But these are the repercussions when we do the partial nephrectomy in a very aggressive and a bigger and higher thing.
That's what
so
we need
have
to keep in mind.
Change our mindset whether it is really appropriate or not.
Yes.
That is the whole thing.
That's it. So
whether now if I relook the intraop images, then probably it was going into vein as well as sinus was involved. Probably that was the reason.
That's exactly the point which we need to see.
Yeah,
we are looking at one single point of ability to clear the tumor completely, and we are very sure of it. Doesn't mean what you see macroscopically alone matters. But there's something more which matters, which we need to keep in mind. 90% of the times you may get away with it, but 10% of the times you definitely get into a recurrence like this, which will make you think twice before you attempt it next time. Right? Makarand was telling about one thing. You see, rarely you see this sort of imaging. You saw that? Something projecting across. How many times we really give a relevance to that? A small bump onto the surface of the tumor. See that? You will see that on the table when you start doing it, and when you start enucleating it, you start seeing that. At one point, you see the thing comes into the vein, and you see the vein seeing there and that bump seen into the vein. So beware. How many times we give that much amount of attention to see that sort of a tumor projecting across from the surface. So see that? You see the vein which is coming up, and there is a bump into the vein which is seen here. That is a tumor into it.
That's different from the previous one.
Yes, exactly.
So here, cases, no, pre-operatively it's locally advanced now. Pre-operative imaging itself, whether we should attempt partial for these kind of cases.
That's exactly what we are talking about, whether we consider it as a locally advanced or due to partial. This is what was the discussion about. When you say it is 2-3A, look into your own thing. You still do a partial or not? Am I right? Mujib, you say you have evidence that this is a T3A disease. When it is T3A disease or possibly looking at a T3A, why are we doing partial? Why can't we do a radical? Am I right? That is what is the point about discussion about. I think Makaran, you can give an option on that. What I would say, I would go back and what is available in the literature. There is an evidence to say, because the problem is today partial indication for partial nephrectomy is your feasibility to do a partial. Indication of radical nephrectomy is your non-feasibility of a partial. So I think the indications have become very clear in present day world. So we need to rethink our indications. Makarand, conclusions. I have got 2-3 evidences to say that the outcomes are going to be the same. But in our before Makarand says, in our thing we had 9 cases. I had 1 recurrence, and this is this case. I had 9 cases which I had venous thrombus on the table which have been excised, and one had a recurrence. Makaran, to conclude on this patient, we go to the next.
Yeah, I think basically we need to look at not only sort of thrombus as sort of a criteria, segmental thrombus. Look at the size, look at the location, look at sort of the other parameters. Ultimately, what is important is the biology of the disease. I think we recently had a meeting in Nadia, then we just looked into all those. Are we extending our limits too far?
That's it.
And this is what it is. I mean, you got away with these kind of patients. Patients didn't have problems, but in tertiary centers, we have seen patients failing, patients coming with sort of, lymph nodes, patients coming with adrenal mets on same side, patients coming with multiple metastases. So it's a word of caution.
Yes.
When I won't say there is a clean line saying that you should do in these cases, we should not.
Yep.
But on imaging, if you feel it's going to be sort of something like an odd histology, you feel there is something a standard classical clear cell RCC with a fair prognosis or oncocytoma, I think you should not do these kind of partial nephrectomies. Go ahead and finish with radical nephrectomy.
Fine. I think this is what is the the thought process which you need to get across. I'm not coming to any conclusions here. Neither I am interested in getting any conclusions here.
So last
Sir.
one, sir, I feel in this case, like sir said, the main culprit was histology, grade 3.
Grade 3.
So whenever we see such tumors or
Very close follow-up.
Correct.
Very close.
That is one thing. Second thing is, if it is localized, like in a vein, we can attempt partial. But whenever it is involving the fat sinus, it could be microscopic. So I would not attempt.
Exactly. But when do you know that? Just because you saw sinus fat there.
No, on imaging, pre-op.
On imaging, of course. You see, the question is, I'm not saying if you had made a preoperative diagnosis to do a partial or not, your justification for it. When I'm talking about when you never knew on the table you see it, then only what is going to be your decision across. Because you're never counseled for a radical nephrectomy at that point of time. Because you're counseled for a partial nephrectomy. Are you going to do a radical or still continue with the partial?
So just while doing partial, we take consent for the radical.
That's because when we fail or there is a bleeding.
No,
90% of the times.
No, but still we take consent for the radical.
95% of the times. Let us accept it. Let us accept it. I take a consent for radical because bloody anything can happen any point of time. So that is the point. Okay, we have a next case. It's a technical related. There is a incidental tumor in a young fellow who went for a mastoid checkup. And we start doing a lap partial nephrectomy, and there's a dissection which is going on. I think it's a little slow video. Okay, I didn't pay fast it. There is some trying to do some dissection for the artery there. The place is wrong. I think you can see that the place is wrong. It is below. It should have been below the lumbar vein clip. It should have gone up below clip. So what happened? There's some bleeding, and after some time, we realized. I came in at that point of time, and we realized, yes. We realized that there is some amount of blueness of the kidney, and we realized that there is an injury to the lower polar artery and then spasm of the artery. So everything is blue. Anyway, that is injured, that's too small for me to repair, so I clipped it off. So what should we do now? It's blue now. That artery is okay. The lower pole is completely blue. What next? Now, I saw it on the, I played from beginning again before it, what I've done I'll show you later. No, I'll come here now again. So, you have seen the video, you tell me now what you're going to do.
Where is the tumor, sir?
It's a posterior tumor.
Lower polar?
No, posterior mid-polar tumor. Mid-polar. Not lower polar, it would have been simple. I would have not presented it.
Sir, do we have an do we have the facility of an ICG?
Yes, I have a facility of ICG. It is not showing much perfusion. I saw a color Doppler.
Malik,
yeah,
so
1 minute. Yeah.
We'll wait for a second.
Okay, we'll just go ahead with the
OT theater.
OT theater for a moment and come back.
Yeah, maybe, sir, you can moderate that in case.
Yeah. Oh yes, Pranjal.